Gail, for joining us. We're thrilled to have you here, virtually, almost live, or live but not in the room. I'm pleased to introduce Gail. She is a professor of social medicine at the University of North Carolina School of Medicine. She was chair of the Department of Social Medicine from 2009 to 2015. She, before that, was also director of the ethics core of their Translation and Clinical Science Institute. Before that, was director of their Center for Genomics and Society, was director of the International Core, their Center for AIDS Research for 10 years. She trained in sociology and has done remarkable work on HIV and other areas in empirical studies of research, of ethics and research ethics. In other words, trying to understand how people in studies understand the ethical issues they face about the study, about informed consent, et cetera. I think she's one of the best people in the country on these issues, and so we're thrilled to have her with us. Were you able to listen into Serena's presentation?
Yes, I heard it all. It was great. It was great.
Okay, so I thought we would start with questions for Serena because you did a great job, of course, and I think there were questions that people did not have a chance to ask you. So the floor is now open. Questions for Serena.
So at the end, you had some of those quotes about kind of reframing what HIV, how to describe HIV Cure Research to participants, and I was wondering, what are some of their motivations for joining these studies, especially when they're doing well? Like, are these people who are desperate to get off treatment, and so they're taking an opportunity to do it while they're being monitored? Or I'm wondering if you could speak a little bit.
Gail, could you hear the question?
Yep, I can hear it.
Okay, great. Okay.
So that question is basically very, very much what Gail was going to be talking about, because she has actually, one thing I didn't say is, I didn't address the issue of, how should we be going forward with these kinds of studies? I just brought up all the issues. And I think one of the key things going forward with these kinds of cure studies is embedding within them social science studies, where there's actually qualitative research going on, there's ethics research going on, thinking about, how are we going to do this in a way that helps us really understand the motivations and the issues that may be unrecognized by the investigators who are running the studies off in their offices, in another nation. And also then what can we do to then improve communication, all these things. And so this is actually what Gail is doing in conjunction with the HIV cure studies that are happening at the site in Bangkok. And she's going to get to exactly the kinds of things you're asking. What are the motivations for these people? Of course, Gail's going to be specifically talking about a certain cohort and their specific cultural and other kinds of things. But I think in my talks with community members of the ACTG, for example, most of the people who are really interested in the cure studies tend to be people who are very, very motivated. They're very knowledgeable already. Most of them are doing really well with their HIV therapy, and they are looking to push the envelope. I haven't gotten the sense that a lot of people are sort of desperately hanging on the edges, barely getting on treatment, and hoping for some cure to take care of it all. People are really, really involved, and they really want to make a difference. They're hoping for a lot of altruistic reasons also to make a difference to the field, and for all the people who are globally living with HIV. But really, Gail, these are my kind of incidental impressions. This is really what Gail is professionally working on in a really systematic way.
I have a second unrelated question. The work on early treatment, are people still going to, because I found that to be really exciting when you think about the movement towards same-day ART initiation, and that could be kind of a motivation to get, I think same-day initiation, it's like, okay, let's reduce all the barriers to linking people to care, but it also be really exciting when you think about the clinical benefits. So the trials have not been all that successful. Is that still an area that people are pursuing?
Absolutely, absolutely. I mean, I think that the HIV cure aspect of it has not been successful so far, still is being pursued. Although I would say that in our Bangkok cohort, we're probably not going to be interrupting people who are receiving one anymore after the experience we had. But certainly lots of cure trials in that community, because the idea is that maybe they would have additional, again, it's the lowest hanging fruit, people with the lowest reservoirs and most likely chance. The other thing is that there's obviously a huge benefit in terms of a lot of other aspects of the medical care to starting treatment early, and there are a lot of studies looking at, decreased resistance, decreased inflammation, benefits to every organ system you can think of starting treatment early. So those studies are certainly ongoing, and I think that the long-term benefits of starting treatment early are just, unfolding as we look at the immune benefits. But so it's not as if it's being dropped because these interruption studies were negative, but I think it's also not being unrealistically hang our hat that that's going to be all you need.
Hi, I'm Ray. Coming from a kind of a sister treatment clinic, I work a lot with hepatitis C and writing the new antiretroviral therapies that were out. So as a provider, as a nurse practitioner in this clinic, a lot of the topics that we talked about once we've cured our patients and they achieved sustained virologic response was long-term follow-up and management. I think there's a lot of misunderstanding when we're regurgitating to patients that all of our secondary, let's say if we can call them complications or comorbidities that have been associated with that, 20, 35 plus years of living with this infection are just going to kind of go away as well. And I think it's still an evolving field in the hepatology world. And now that we have cured or we have achieved the same virologic response, there's always the risk of reinfection. And we tackled a lot of that with our patients. And I'm wondering to see if some of these HIV advancements and what we're deeming as cure, how that's going to unfold and how we communicate with patients. And like I said, I dealt a lot with that and how we delivered the message. And so I was wondering what your thoughts were on that. And, is the field also looking into continued long-term management with these patients that we have, achieved sustained virologic response?
That's a fantastic comment.
Yeah.
And it's so interesting to think that you have the benefit of seeing this goal that, HIV Cure is not able to do, and you've done it. It is a really, really important question. I mean, of course, people aren't really there yet because we haven't had this and essentially, you're absolutely right. And then, of course, the reinfection, Timothy Ray Brown says openly he's on PrEP. So all of this, it's great. You don't have to be treated for HIV, but you're still being treated for HIV, really, in a way. It's kind of an interesting thing, right? I mean, it's good that he is. It's great because he's realizing that, people get reinfected. But certainly there is, and for him in particular, I think he would openly say, because of everything he's gone through, the stem cell transplants, and graft versus host disease, and everything he's had, he's living with a lot of long-term consequences of the HIV and everything else that he went through to be cured. Again, he's our one example, but I think that you're absolutely right that there's going to have to be a recognition of how do you maintain people's safety and health and safe sex practices and all these kinds of things in the setting of an HIV cure. And then we're going to have, I think the HIV field, if it ever gets there, would be looking to the HPV field and other things to get to that.
Again, such a terrific talk earlier. When you talked about gene therapy, I'm sure this will probably come up in this seminar we're about to enter, but from a medical or biological perspective, how high is the concern about unforeseen consequences of any kind of gene therapy?
I think it's really high. And clearly, there have been unforeseen consequences of other kinds of gene therapy studies. People have actually died from complications of gene therapies. I'm not really involved in those studies, so I don't know how they do the consent process, et cetera. But this is where those kinds of things of having a social scientist or somebody embedded in the team who's really kind of looking at how people are consented for those studies. I mean, I think the investigators are probably highly concerned about complications, and I'm sure they have all those complications listed in the consent form. But also the investigators are really motivated to find out whether or not this will be effective. And so I don't know how that's transmitted to participants and how that's weighed in.
But more specifically with the CCR5 defect, are you aware of any consequence? I mean, is that the only thing that it affects in the body?
It's really interesting. CCR5 is linked to all sorts of cells.
Okay.
But on the other hand, people are inherently endogenously lack the CCR5 receptor, People are CCR5 homozygous negative, such as the donor to Timothy Brown, and these people are healthy. There are certain things, like I guess people who lack CCR5 are more prone to getting influenza and also West Nile virus severely. So there probably are some things that would be negative, but again, those are ways. and
Yeah.
other kind of cellular functions, even though there's CCR5 receptors on all sorts of cells in our bodies, seem to be pretty normal.
There was a recent article in the latest Nature Medicine published, and they looked at the mathematical model of life expectancy among people who actually had the CCR5 gene edited, and they expected the gene editing would decrease life expectancy, but also any flavivirus. The host will be more susceptible to any flavivirus, dengue, West Nile, yellow fever, Hep C, any flavivirus.
Flavy? F-L-A-V-I, Flavy.
Any flavivirus would be high risk of infection.
Okay, interesting.
It's very interesting.
Thank you.
Just this past week.
Correct.
Yeah, Monday, I
Correct.
think came out, yeah.
Huh.
I was wondering actually about, you mentioned use of zinc fingers, but not of CRISPR. I was wondering if CRISPR is
CRISPR
used.
has also been used.
Right.
Yeah.
Yeah.
So, absolutely.
All right. So, and I just didn't answer your question, Bob. So my understanding is the diseases for which gene therapies have now been approved, and there have been 2 approved, are severe disease which there's no other treatment at all. So the feeling is that even though there's risks of gene therapy, it's sort of gene therapy or death. So people prefer to take the potential benefit over the risk.
Yeah.
Okay, so we're going to have Gail speak, and I thought for Gail's benefit, if everyone might just go around very briefly and just introduce themselves, so Gail can have a sense of the audience. That would be terrific. So, please.
I'm Brian Cutner. I'm a postdoctoral fellow at the HIV Center.
He's not on the camera.
Okay.
Oh, hi. I'm Brian Cutner. I'm a clinical psychologist, and I'm a postdoctoral fellow at the HIV Center.
I was going to move it. I don't want to.
I'm Nadia Nguyen. I'm also a postdoc at the HIV Center. Got my PhD at UNC.
And do you want to just say your discipline, your PhD?
Epidemiology.
And,
Clinical psychology.
okay.
That's great.
I'm Jagadisha Deva Sridekis. I'm a social worker. I'm also a postdoctoral fellow here at the HIV.
Okay, sorry. Hi, I'm Ray Gannon. I am a clinical adult geriatric nurse practitioner, and I have my PhD in nursing, and I'm a postdoc fellow at the HIV Center.
Hi, I'm Shay Bridas. I'm in the Master's in Bioethics program here at Columbia. Hi, I'm Sabrina Thompson. I'm an undergraduate at Barnard College, volunteering for the Bioethics program.
Hi, I'm a clinical pharmacologist, infectious diseases, my assistant professor at Toro, and I do work with the Callalord FD HIV co-infected cohort.
I'm Theo Sandvoort. I'm a social psychologist and do HIV research with MSM in Africa.
Hi, I'm Patrick Wilson. I'm a community psychologist, and I co-direct the development core with Theo here at the HIV Center.
I'm James Colgrove. I'm a professor in the Department of Socio-Medical Sciences at the School of Public Health. My disciplines are public health, ethics, and history.
Bob, you know.
Hi, Gail. I'm Bob Remian. I'm a psychologist, director of the HIV Center here. And when I saw Mike last week, he told me to take care of you while you were in New York, but you're there, so you're well taken care of, I'm sure.
Oh, yeah.
Say
Well,
hi to Mike.
Actually.
Okay.
Hi, I'm Ron Bayer. I'm in the Department of Socio-Medical Sciences. I am interested in public health ethics. And
Right. I know.
Me, you know, Stu, you know.
Hi, I'm Anthony Santoro. I'm a clinical psychologist and postdoc researcher, fellow at the HIV Center.
Great.
Okay.
That's it.
Very nice to meet you all. Yeah. But you can just pretend I'm sitting next to you. And I wanted to just say a couple things. I was really looking forward to coming to this. I'm sorry I couldn't be there. But I also want you to just feel like, I'm going to go through slides, but please feel like you should interrupt me. I also want to make sure you can hear me okay.
Yes, very well.
Yeah, great.
I told Bob to interrupt me also, so don't be surprised when he does. But I do have some slides to go through. The goals are to give you an idea of, this really follows up so nicely from Serena's lovely presentation, to give you an idea of the work that we've done with Jintanat Anuranowicz in Bangkok, with a cohort of people recruited to 4 trials. And I want to introduce you to the ethical concerns that people have, Actually, I'm getting an echo. Are you?
No.
Okay.
No, we're not.
No problem then. So I'm going to run through the slides, and again, stop me at any time. And I put the first one on. Serena had one as well about what cure means to you. That was done by a young man in Thailand who was part of the cohort. So Bob told me to talk about ethical conundrums, and I think Serena's talk is a great example of the fact that cure researchers are constantly aware of these. It is not at all unusual to have people, like Serena did at the end of the talk, outline a number of difficulties that they're worried about with regard to recruiting people into these kinds of trials. So that was a great segue. And what I want to focus on is a couple of things. One is that the so-called empirical bioethics, what on earth that is, I'm never quite sure. But if you are a social behavioral researcher and you are interested in questions that have empirical bioethics implications or implications about challenging ethical problems, then you collect information just as the woman whose name I forgot now asked about what are the motivations, should we be worried about them? But much harder to assess is normative implications. Should these kinds of trials be conducted at all? And so at a societal level, or the level of IRB review, and at the level of a debate in the bioethics literature, are these trials ethical? And we're going to talk about that a little. At a community level, and here I'm not just talking about community activists, but also the level in the communities from which people are recruited. How does and in this case with Thailand, how does the community in Bangkok and the search cohort, and specifically, how does that impact the trials and people's ideas about the trials? And then, of course, at the individual level, are individuals making voluntary choices, and which is what we worry about, because they're very unfavorable risk-benefit ratios. I'm trying to push down the pictures of me so I can see my slides. Can you see my slides okay?
Yes, yeah, it's been very well.
Okay. So then the question is, how do we address these? And that is first, and this I'll run through really quickly, there are a lot of studies of decision-making, so participant decision-making in early phase trials. And I've done some in gene therapy trials and other kinds of early phase cancer trials. So you have, this is the phases of a clinical trial, which I'm sure you know all very well, but just to put in a picture as opposed to a bunch of text. But there's phase 1 studies with healthy volunteers, which are run often by big centers testing pharmaceutical products. And there's early phase experiments with cancer patients. Those are among the two that are the most commonly studied in terms of decision making. They're different patient, or rather participant populations. And Serena already went over this. There's something quite different about the HIV remission trials context. So participants aren't healthy volunteers, although interestingly, the FDA just published a notice that we could about them as healthy volunteers. And that's something I find interesting and a bit surprising. But they're also not patients without treatment options. They're, as Serena outlined, they're doing very well on ART, and so ART interruption involves a major ethical challenge. And that's one of the things that's most interesting about these trials. And the 4 trials I studied in Thailand all involved treatment interruption. So just to look at the challenge. So in early phase remission trials, there's almost no possibility of direct medical benefits and significant unknown risks from study interventions, invasive procedures, and treatment interruption. So a bioethicist at Harvard named Nir Eyal published an article that called this a bad deal. So it is a bad deal in the sense that the risk-benefit ratio is quite poor for participants. So what could ethically justify this? Now, the common rule, which of course governs all of our research, is a federal regulation, says that IRB approval of research requires that risks to subjects are reasonable in relation to anticipated benefits, if any, to subjects, and to the importance of the knowledge that may be reasonably expected. And so that's the sort of classic benefit to self, benefit to society. And if the risk-benefit challenge is, as Neer and others have documented, poor, that there's a lot of potential risks, no benefits, then how could you improve that challenge? Well, very simply, reducing the risks, increasing the benefits, focusing on making sure informed consent is really well done, and then considering a focus on the societal value as opposed to the benefit to the individuals. So I'm going to just go through these really quickly. Reducing the risks is what people with phase 1 trials do. They do animal testing, they exclude participants with comorbidities, they try and minimize the risk of interventions, and they have very intensive monitoring of viral load in the ATI studies that Serena described and that we studied. So these are issues that are hard to resolve. How do you reduce the risk of experimental interventions whose risks are essentially unknown? And the gene therapy studies are classic examples of that. And if there's irreducible risk, we could try and improve the risk-benefit calculus, but it's still unfavorable. So what about increasing the benefits? Here we might think about inclusion benefits, which are medical benefits that accrue to participants not related to the experimental intervention. This has been well described in the literature, and participants often mention this when they talk in studies like the ones I do about what they consider to be the benefits from a trial. This could be closer supervision, access to excellent doctors, and just monitoring overall. They see this as benefits to themselves, not from the intervention. Could increase participant incentives. This is somewhat controversial. As you see below, it's not necessarily advocated by all, because it could be seen as coercive, increase the amount of money you pay for people to participate. And could acknowledge that there are really psychological benefits in contributing to research and better future treatments, and seeing those as also ultimately benefiting themselves. My issues there are it's really difficult to define and measure inclusion benefits. And again, paying people to go off their meds, I could see a headline in the New York Times about that. And how about existential benefits? How do we define and measure those? And how can they offset risks? Focusing on informed consent is a big issue. And that is one of the reasons I got involved in this, because the PI of this whole search cohort, Dr. Gintinat, as she's called, because it takes us years to learn how to say her last name, she was really concerned that it was a proper informed consent process for these participants in the Cure trials. So a question then is, when are we, if ever, permitted to let participants accept what looks like a bad deal? I mean, these are autonomous adults. Isn't it their right to make a bad decision for themselves? And do we have an obligation to understand how they understand and weigh possible benefits and harms? And these are the issues as I wrote below. It has to do with how do we assess whether people are really well-informed and autonomous, and making a decision that corresponds to their value system. And then from a different vein, if no benefits are okay for individuals, which I would say, why not? It may ultimately undermine public trust if things go wrong, and want to really think carefully about that. And then finally, in terms of addressing the bad deal that a bad risk-benefit ratio entails, we want to focus more on societal benefit. And the question here is simply, does a research study need to have favorable risk-benefit ratio for participants to be ethical? So what about no benefit at all? And a lot of early phase trials in cancer and other fields don't have any medical benefit to the participants, but should have plenty of potential societal benefit long term. And so it would be ethically justifiable on those grounds. Now, on the other hand, what if the trials don't lead to successful interventions? And of course, implementation science and all of the down the road barriers to adopting even a quite successful result are important to think about. Just because you have a positive result in a trial doesn't guarantee translating to something that will be valuable to society, and there's a lot of financial and other kind of barriers. And Serena mentioned a really important concern there, which is the notion that you don't have unlimited dollars, and if you spend a lot of money on cure trials, what are you not spending money on? There's lots of areas that HIV community activists are really concerned are not getting enough funding in lieu of this, sexy topic. Okay, so all of that sort of leads to this idea that threading through this challenge and all the four responses are, what are the motivations of participants? Why would people choose to join them? And what does their own personal risk-benefit calculus entail? And progress on this challenge, as a social scientist, I would say, I would advocate that it can be made by exploring how people in actual real world situations come to the decisions they come to. Okay, and this leads me to featuring my really dream collaborator since I met her in 2014 at the Brochet Foundation workshop, Dr. Jintanat, who has since just recently gone on to the Gates Foundation, but started the search cohort in Bangkok and has overseen the trials that Serena referred to and many others. So here is just a little brief description of the cohort. Started 9 years ago, screened hundreds of thousands of samples. Now there's almost 600 people who are identified with early infection and started on early ART, mostly male, MSM, younger, better educated, and in search is considered to be a research study as well as a cohort, and this is the cohort from which all the cure trial participants are recruited. And there are 4 trials, I won't go into them, but one Serena talked about, which is RV411, and that is the people who were identified in FEBIG1 very, very early, and the hypothesis was if they are taken off ART, that they will take longer to rebound, and sadly, I think Serena said tragically, that hypothesis was disproven. 3 other trials involve an intervention and placebo. So these are the trials. They're small. They're no more than 25 participants. RV411 had 8, and then was going to have another 8 until it was not. It didn't merit going forward. And these are the people who we have interviewed. This is our design. This is the decision-making study for the Bangkok cohort. And so I would just want to say this is a dream study. I have, in addition to the dream collaborator, this is a study that has allowed for us to survey potential participants about their intentions, and then those who join, as well as those who decline 4 different trials. And we interviewed them over time, longitudinally. We have several aims in our R01, but it's usually people who are trying to figure out what motivated study participants, are unfortunately stuck with retrospective interviews with individuals who are reconstructing a decision. We interviewed people qualitatively, and we had a decision conflict scale. We administered it at every interview. So we really catch them in real time, and their decisions to join or not join were assessed by themselves, and we asked them, what did you think about your decision at the end as well? So I'm not going to go through this in detail. We'd have 54 participants that we interviewed and 20 decliners. The participants were interviewed at the beginning and in the middle when they went off their ART, and in the final interview. In a particularly long trial we had, which was a vaccine study, we had 4 interviews. And for each of these, we had similar questions, but then questions that had to do with where they were in the trial. And the decliners had almost all of the same questions, but just, what would have made you change your mind? Is there something that would have, about a trial that if you had it to do over again, you might decide to participate? And so we got some interesting responses to that. So I'm going to stop here for a sec. The rest of my talk presents our results, but I wondered if anybody has any comments or questions before I move forward.
Gail, you suggested the other study ended early, and I'm just wondering if you might want to comment on that. Was that a difficult decision, or what, or when it ended, why then?
I would ask Serena to chime in. I think she knows that study just as well or better than I. That was RV411.
Yeah, I mean, I think there was a kind of go, no-go criteria for enrolling additional participants. So it wasn't that it was ended early, but they basically said if nobody in the first eight people has any kind of viral control, they would not go forward and enroll additional participants. So there was sort of it was structured in such a way. It wasn't as if they had planned for 20 and they just stopped it early. They sort of said after the first 8, they'd take stock of what the responses were, and if there looked like there was anything promising, they would enroll additional, I can't remember how many, additional, we'll say on 13 or something like that. And since all of those 8 rebounded so early, they decided it met the no-go criteria and they had to stop the study.
I mean, just one question, again, this is 2020 hindsight, should they have said after 4 people to stop it, or why wait till 8? I mean, after 6, if they're all rebounding, I mean, maybe just a thought.
I think, based on the Visconti study, it was about 10% of people who were controllers. So they decided to go with the 8 number, thinking that maybe 1 in those would be a control. It's all, yeah.
But there was a rationale.
There was, and it was predetermined. Gail, I have a question. I never thought about this before, but in your studies, there must have been a consent process to join your study.
Yeah. Oh, wait, I forgot. The consent process for ours was initiated at the very beginning of doing the baseline survey, and it was consenting people in the search cohort to to take a survey. But at that point, it was only 250 people in the cohort. This was 2015-16, and they also agreed to be contacted if they were recruited to one of these trials. And then when they were, or if they were, then we asked them again if they would participate. But maybe about, I think 85% of people agreed. And this was if they were contacted. And so you can see that they were recruited to join the trial. They either joined or declined. And then we conducted the first interview really close to that decision point. A few people said no to us, but the great majority said yes. And among decliners, we simply took the first ones that were identified by the search team. One important point is that the search team knew who was being invited into our study. because they were facilitating our interviews. On the other hand, they had no access to the actual interview data, so the transcripts. So this is a really interesting thing about doing a social science study alongside a clinical trial, where we needed and wanted the expertise and the logistical help of the clinical trial folks, and yet we assured our interview subjects that they would not see the interviews, and they did not. We only brought them back into our papers at the point of analysis already conducted on the transcripts themselves. There was but that's a pretty interesting and important component for anybody who's thinking about doing this kind of a study, that you've got a lot of sensitive boundaries that we needed to draw, and sometimes we did it kind of, oh wait, we need to draw this boundary, and certainly everyone in the search team was very helpful and understanding of this. Okay, so oh yeah,
one more question. Yes.
Okay.
My question is, did you get any pushback from the clinical trial people about the questions that you're asking? And maybe I'm wondering if there's a fear that you'd stir up concerns that people didn't have, people would drop out of the study, or they'd want to start their ART sooner.
You know, I mean, that's a really great question, and it is. First of all, the interview guides were approved by the Chula Longhorn IRB and two of the search leaders, Jintanat being one, and the other, the local PI, Eugene Kroon, who's a Dutch infectious disease physician, lives and works in Bangkok. They knew what the questions were. And the questions are very focused on the decision-making process. They're not focused on a kind of gotcha. But what you're saying is maybe we would be confronted with something quite challenging if we found concerning reports. And so we had a process where we had identified if somebody says something that is, you know, concerning about their health, concerning about the process itself of recruitment, that we would report those anonymously. And making it anonymous with such small studies was really challenging, but we would do that. But the other thing is, it came up in the ways that we wrote about papers. And the slide I just pulled up, I want to show you, because this identified a really challenging thing. So the search cohort is the home for 600 or so individuals who identify as being cohort members. They get their care there for the most part. When they were diagnosed, many said it was their best choice for treatment, although later, when the Thai government funded ART, which was after 2014, the other choices were reasonable, but certainly early on, joining the cohort was almost a non-choice. But they also felt special. In the beginning, there were not as many, and they got to know the clinicians and the study coordinators and the research nurses very well. The other thing is that being in search, we found from our interviews, for some people transformed their identity, so that they knew. And I was thinking a lot about this when Serena gave her talk. These are people who have bodies that may be uniquely qualified for HIV cure research and for controlling the virus. And they were told that. They were not told you have special bodies, but they were told about their status, about how important it was to stay on ART, to suppress the HIV virus, and how and a number of them who were PHEBIG1, as Serena described, were antibody negative still. So they hadn't even become antibody positive. They were caught so early. So a number of people mentioned this when they talked about why they joined their trials. You know, the antibody negative folks felt almost normal although if you read other research about people who have been quite sick with HIV and AIDS and then start on ART, they say ART makes them feel normal. So normal is a really interesting concept. And they also had close relationships with the search staff, which there's no question blur the boundaries between research and care. This happens all over the world. This happens in all kinds of research studies. But you can see that if somebody said, well, I joined because, you know, nurse P.on thought it would be good, well, what would you say to that? Is that concerning, or is that a reasonable thing? Somebody is influenced by a caregiver. Again, this is not an easy issue, and it has to rise to a level of real undue influence rather than simply influence. But understanding where people were recruited, like how the impact of the search cohort was part of our process. It's really important. Recruitment from research cohorts is now increasingly common in HIV work and cancer trials. It makes it easier for investigators, but it also comes with it a number of issues that people who are interested in research ethics will focus on. So when we talked about maybe something that was concerning, but then we wrote about it in this much broader context, because I think it's not something that you can address except through being really transparent. Okay, so I don't know if that might have been a little too much, but let me go on, unless people have other questions.
Were they all cisgendered? And did the route of transmission or acquisition of the virus make a difference at all?
You know, almost all of them acquired the virus through their MSM relationships. Its drug use was extremely low, although it was a little bit increasing in the last year or two. And because this is the only cohort I studied, I don't know the answer to your question. I assume it is quite important, but I don't have a comparison.
Most of them are cisgender. Oh. There's another site that has not.
So you're just saying they were all cisgender?
Yeah, I think they're mostly all cisgender, right?
Yes. Oh, I'm sorry. Oh, I think there may be a few trans people in the search cohort, but maybe others would know that more than I.
Just a few, if there are.
Okay. But there weren't any people that we interviewed that talked about that. Okay, so let me talk about our results generally. When we asked about their decisions, what they saw as the risks and benefits, you know, why they decided to join, what were their hopes and expectations, there's a broad range. Many joined to stop ART, as Serena described. This was a benefit that it's not described in any consent form as a benefit, it's described as a risk. But the people we interviewed who joined, and even those who decided to decline, thought that this was a big benefit of being in the study. And in the study under careful monitoring. So they felt that being in search and understanding and knowing the people who would be taking care of them they felt safe. They also reported motivations of, wanting to help others, wanting to help their community, other people in search, and so on. And they seemed quite knowledgeable about the risks of both treatment interruption and the interventions. And I've included a few quotes because I think it brings home what the people said specifically, and I like that. So one participant said, "I want to stop." And by the way, these are from the 411 trial, which is the one that was simply treatment interruption. "Yes, I want to stop. Sometimes I want to challenge myself. What will happen if I stop the medicine? The staff told me there's only a few people who match with the requirements of the study. So I think if I am the one who can be involved in the development, I should do it." So here's an example of what they thought about themselves as having these pretty special bodies. And then the last one, if the virus increases, my worry is the anti-HIV, the test result will change. So, but from the prevention plan, if the viral load rebounds until it reaches their criteria, I'll start the drug immediately, I think it can protect me. Now, this has to do with that they're antibody negative, and then, as Serena said, 4 of them switched to being antibody positive during. But Serena, interestingly, either Eugene or Don told me that 2 of those who had seroconverted actually seroreverted, which is surprising and doesn't mean much, only 2 people, but still 2 of the 4 actually went back to being seronegative. I don't know how that can happen, but that's what they told me. So then some decliner quotes. So there's no result from any research that you can stop the drug after you only took it for 2 or 3 years, even though, and they're talking about ART, even though you started the ART earlier, there's no guarantee. The nurse, the doctor, they never researched this topic before. We're the first group, so I'd rather wait. So this is what you want decliners to say. Like, I'm worried about the uncertainty of this. This is so new. I don't want to be part of the first study ever to do this. I'm not going to do it. Another said, sometimes I'm afraid that if I participate, I'll have to do everything they say, even if I don't want to. Now, this person declined. So while he was afraid, I think it might have been one of the few women, she didn't do it. And she also declined an invitation to a 4th cure trial. Okay, and a final decliner interview, this came from a different trial that did have an intervention, which I thought it was, I wanted to show you this because the decliners also have a lot of altruistic ideas, and it's not, and I'll show you in a minute, they don't 100% feel good about their decision. So if you see that the interviewer said, what would you tell someone else about joining? And he said, if you want to do something useful, if you want to be a part of this history, devote your time, use your HIV positive status to do something useful for the next generation. In the past, the drug we were taking was developed because HIV positive volunteers tried it, and we have it now. It's the same as we make history for the next generation. So this is quite moving, I think, and I think what I was trying to do here was show you the range of responses in a very short period of time. This is something that people are really favor to give a snapshot, like, okay, here are all the things they said, but basically, here are all the things they said, and for joiners and decliners, and some of this was covered in the quotes. And what I think is more important from a social science view is that the same benefits and harms were identified by participants and decliners, but they just valued them differently. Again, this is what you want to see. You want to see people making informed consent decisions that align with people's values. So for example, close monitoring was seen as a burden by decliners. They had to come in every week, sometimes twice a week. Participants identified the benefits of that, and so on. And altruism, a strong motivation, but not enough for decliners. So, and then during the interviews, people reported changes in the way they perceived what was going on. And I think this is the value of a longitudinal study like this. So initially there was this tremendous allure of stopping your ART, but later people said they were just worried all the time. And in fact, a couple of the people in the year-long vaccine trial eventually just decided to go back on ART because they were simply too worried. And you know, if you have to go in and be monitored every week or every 2 weeks in that trial, you're just anxious and just want to get it over with, at least some. The trial burden was higher than people thought. Optional procedures also somewhat more burdensome than people thought. And Serena talked about the distress for people who seroconverted. And then nevertheless, overall trial satisfaction was high. And so even after people rebounded, and if you think back to what Serena talked about with RV411, that trial where people rebounded so quickly, and in the other trials rebound, except for basically 2 individuals who went much, much longer, everybody rebounded. Nevertheless, people were satisfied. Now, why is, and that's, I think, another really interesting question. And here's something that I'm trying to give you a sense of the range of motivations, of perceptions, but also one person said all these things during one interview. And this was right after he restarted his ART, he just rebounded. He said, and this was a trial that had an intervention. It was a monoclonal antibody. I questioned whether the drug is suitable for me. If forever, that'd be great, but if not, that's okay. I have to come here every day, and sometimes I wait for the whole day. So he's frustrated about that. And then he sort of checks himself, but wait, it was me who asked the nurses if I could join the study. And some of the people were simply waiting until these studies rolled out. They were so excited about the possibility of participating. Once I stopped ART, my quality of life was great. And of course, then he's gone back to ART. I was so scared on the first day I returned to ART. I'm fine now. Now my same life is back. I feel sad a bit, but not that much. So you can see the range of feelings and thoughts about this. And this is, again, just one participant. Now, the next small section.
Question. You have two questions.
Okay.
So, third bullet point, once I stopped my ART, my quality of life was great. Makes me think they were on some old antiretroviral regimen with a lot of side effects, or did that not matter?
Well, I'd let Serena answer this if she's still there. I know she has to go to another call, but I think that they were just taking once a day up, state-of-the-art ART. But Serena?
Yeah, so the beginning of the study, they were taking etriplet, which was kind of what was standard at the time, in 2009, whatever. And then in the last couple of years now, it's a dolutegravir-based regimen. So single pill a day, simple to take, theoretically, et cetera.
So it wasn't really about side effects, you don't think?
I don't think it had anything to do with side effects.
Is it about the burden of?
Yeah. Burden of having chemotherapy. I mean, I shouldn't say it had nothing to do with side effects, but people didn't, we haven't had that many people in the study switch regimens, for example, due to tolerability of side effects.
This is related. I was
I
wondering
just want to add about that in our interviews, we started out by asking people about their experience becoming HIV positive and joining Search, and then their decision to be in the Cure trial. And I cannot tell you how many times people talked about the burdens of having to take their medicines, having to hide them, and Serena said worried about going on a trip that would be longer than 30 days, about the hiding from their family, from their friends, having to take it at just the right time and therefore setting an alarm. And when that alarm goes off, feeling it's stigmatizing because everybody must know. This was a really big deal, at least for some, maybe not every single person, but it was impressive how much, because it reminded them, they would say, it reminds me what I am every day.
So this is a related question. I was wondering if bullet point 3 and the topic you just discussed are related to the comment in 4. I feel sad a bit, not that much. I'm wondering what they felt sad about, like the loss of being able to feel like maybe I'm free from HIV finally, or is it something else?
Yeah, that's a good question. And of course, the trying to prepare a talk that is so short when we have 175 interviews with so many different kinds of people, it does such a disservice to the nuance. But this was kind of common. So they had a bunch of hopes for HIV remission research. And they didn't expect to be cured, but they really, in the back of their minds, they thought, maybe it'll be me. Maybe I'll be able to stay off for a year. A number of people had an idea they could stay off quite a bit longer than they did. But they also were realistic, and the study team consented them, I think, well, that, this is not guaranteed. This is why we're doing it. So I think sad a bit is about, now, it's a very interesting issue for us that people felt if the trial failed, some of them may have also felt that they failed. It was a failure of their bodies. It's not clear to me that this person said all that, but a number of people did feel that their bodies didn't, if they'd had really good bodies for Cure Research, they would have not failed, and the trial would not have failed. So, and which I think is something that people who recruit participants need to be really careful about when they return the results about the trial, which of course everybody has heard about, to talk to people about their feelings about their own bodies. Because this was a big motivator for at least these particular participants. I'm glad you asked that question. It's a really good question. So, okay, I go on. I'm not too far from being done, actually. And I really encourage you to interrupt more. So I told you we had decision satisfaction or decision conflict measure embedded in every single interview. And we wanted to look over time and between trials and between joiners and decliners. How satisfied were they with their decision? How much conflict did they feel about making their decision? And this is a very well validated measure. It has 16 items, and they explore, were they informed? Is it consistent with their values? Were they supported and not pressured? Did they feel certainty about their choice, and how satisfied were they with their decision? So, and our preliminary findings were that people were relatively satisfied, and that persisted over time. And I'm just showing you a couple of box graphs that show both participants and decliners, and this was across the different trials. And you can see that, well, and I wanted to say 409, I have to admit, was a retrospective interview. We didn't get in there in time. So that you could just not look at those data. However, they're not too dissimilar from the other data. And you can see that decliners have, in these 3 trials, because we didn't do decliners in 409, have a somewhat higher level of dissatisfaction. And you see that also by the visit. So visit 1, 2, 3, and 4. As I said, a couple of the participants, one of the participant trials had 4 visits, 4 interviews, not 3. And the decliners just were interviewed at the beginning and the end. And you can see, again, this trend that it didn't change a lot over time, but the decliners were somewhat less satisfied. Now, these scores, you notice it only goes up to 60. It should go up to 100. And so these are relative satisfaction compared to other studies about decision-making in other contexts. So I just want to point out that they were, generally speaking, satisfied with their decisions. That didn't change. It didn't change when they rebounded, and it didn't change at the end of the trial. So I think that's pretty good in terms of thinking about the way the search team should understand what happened to these participants. But we were concerned that what's going on, that some decliners seemed more ambivalent about their decision. So I want to say, first, decliners basically were worried about things. They felt healthy on ART. They were happy in search. They thought they were, by being in search, they were participating in research. So, and a couple of the decliners were definitely worried they'd get a placebo in the 3 trials that had them. So they declined. So I think having decliners generally is a good sign that you're doing something right. But, and some, many said they didn't have time. But one said he'd like to be getting those optional procedures, which I think is really funny because some of them are really invasive, but he called them awesome. No one gets testing as often as we do, so hooray. That's he regret. But then the last thing I think is concerning. And it's just concerning because it's important the investigators understand this and support decliners in their motivations, because a number of people said they felt selfish about the decision. They saw the value in the research. They saw that being a participant, it was one said it's beyond price. So they felt selfish. Now, several of the decliners were worried about seroconverting, as well they should be. It was such a big deal to them to be seronegative. But still, what should we do about people feeling selfish about the decision? And you think also about the context in the search cohort, that you're saying no to somebody who is giving you care, has been there for you when you've just been diagnosed, and so on. So I think it's a little problematic. It's just something that people don't often get to interview decliners, so it's a special part of our project. Okay, so what would we say about voluntary? Oh, sorry, go ahead.
Is it okay to interrupt?
Yes.
Okay. I have a question. Were there any analyses done looking at differences between the people who accepted and the people who declined, like in terms of demographics, or maybe even like trait anxiety, or any differences between the two groups?
So numbers are very small, but and trait anxiety is something that I think that the search team collects. They collect psychological measures. We had two of the decliners, so I'm not showing you the two highest in decliners on the right hand side. The decliners, two that were highest were ones that expressed a tremendous amount of anxiety. So, and that's all I can say. It's two among 6 or 2 among 20. It's just not, the numbers are too small. But I think you're pointing to something that's quite important. So what would we conclude from that? I think, well, one is, one was so anxious that our interviewer went to the team and said, this person could do with counseling. And I think that was important that she did that. Another thing is, if they're so anxious and they're so worried that a couple of these felt that they weren't healthy enough to be a good cure trial participant. Now, what does that mean? I mean, first, we're glad they declined, right? But second, again, I think it's important for people to really talk to decliners about what's going on with their decision. The push is to not push. The push is to say, accept the decliner saying no, and that's fine. Accept somebody who withdraws, that's fine. But I think in this case, with these people who are, in a very complicated setting, it's really important to, go a little further to talk to them about what's going on psychologically with them. So that's a really good question.
It's really fascinating and thank you for doing this research, because it has me thinking about how even approaching someone, right, to participate can be an adverse event, and how do we take the privilege of having access to these cohorts, right, and how do we protect them, also how do we, do this groundbreaking research? So I think that this is so important, what you're talking about.
Wow,
I think it's important. I think it's important that you talk about how important it is to probe the motivation and feelings of the decliners. I wonder whether you feel it's so as important to probe the emotions and feelings of the acceptors. I mean, you want acceptance, so
yeah.
Do you think acceptance is a problem?
Well, one of the things, okay, let me just go really close, because I'm thinking we're not going to get to this anyway. So this is the last slide. Oh, except for that slide. One of the things, that's my collaborator, Holly P.A., and there's Dr. Jintanat at a conference in Bangkok. And so one of the things that our grant is trying to do is work on a variety of sort of guidance documents, points to consider documents and this is part of a paper we published in just this winter in the journal in J-AIDS, where in each of these points has a paragraph under it. But we, this is what we recommend. So and it's what you were saying, explore participants' understandings, expectations, and identify areas where additional education discussion is needed. Well, that sounds very you know, just almost prosaic. Of course, you should do that. But the things that we've identified are really, if you go to the third point, that consider the specific implications of recruiting people diagnosed at the acute stage, which is what we were have identified in terms of feeling I'm the best for this, but what if I fail? And so number 4 is rebound may be seen as a personal failure, not just a trial failure. And that's something that I don't think we've read in the literature. I think it's, once you see it, you think, well, that's obvious. And there's all kinds of ways that people have talked to us about their viral load rebounding. For example, we asked people in a trial with placebos, when they found out they were in the placebo group versus in the intervention group, what did they think? And some of them said, oh, well, I rebounded because I was in the placebo group. That's a good thing. That means my rebound wasn't in relation to the intervention. So you see what I'm saying? So the calculus for them was finding about placebo was a good thing. Now, and so I think a lot more needs to be done if people are really going to be doing these treatment interruption trials and looking at viral rebound. Much more needs to be done about how people really think about viral rebound in their own bodies. Because it's a complicated, it's just, I made the point already, it's complicated. And then the second point is simply understanding motivations for and implications of declining and providing support for decliners who I think typically are not followed up because there's sort of prohibitions. Nobody should be pursuing them, right? But I think we can offer a little, guidance on that.
It's often hard to get decline research. Gail, my sense is that it's often very hard in a lot of studies to get decliners who know I don't want to be in the study. Oh, well, you could be in the study about why you don't want to be in the study a lot. Don't want to do it.
Right. But one thing I think is interesting and might be at least one antidote to that. I think the more people are recruited from cohorts instead of just de novo, like you're in a clinic, that being in a cohort is a separate kind of identity, and it may be you would say, gosh, understand you might not want to do this, but it would be helpful to us and to the cohort. So again, this sounds a little manipulative, right? But I think people in cohorts already might be more willing.
Do you think if you gave them some motivation, some immediate motivation, the percentage of the people who declined would be less?
Oh, I couldn't hear the first part of your question.
I was wondering if you would have modified the selection criteria by giving them a motive, like here, a Metro card or some financial, for example, reward that they can use immediately, as opposed to sure, yeah, I'm doing something for the next generation, people with HIV. Do you think that would have changed the percentage of the participants or the people who declined?
Who declined to participate in the trial, not in my interviews, right?
Sure. Yeah.
Yeah. Well, they do get compensation for being in the trial. It's not a lot, but every time they visit, which is what a couple of people said, I really want to do this optional procedures because every time I come, I get paid. I don't know what Serena thinks about that. Maybe she had to leave already. Yes? Oh, shoot, you can't hear me. Let's see. Huh. Okay, maybe try again. Try to open again. Yeah. Yeah, I think the GoToMeeting kind of clicks off after a certain period of time. But can you hear me?
Yeah, go ahead.
Okay, and did you hear my comment about the people who are getting paid more and more when they do more and more optional procedures?
We didn't hear your answer to the question about more compensation of that.
Okay, so they do get compensated, and this is for the trial, and they get paid every visit, and it's reimbursement for travel, et cetera. It's not a lot, but and then I sort of joked, but not joked, that a couple of people said that they wanted to do more and more optional procedures because they got paid every time they did one. And I thought Serena's interested in optional procedures and the reasons people do or don't do them, because they're burdensome. Some of them are quite burdensome. Lymph node biopsy, for example. And did Serena have to leave? I know she had to leave. Yeah. Okay. So I have other points, but I also think you guys you've been here for quite a while, and it just strikes me there's sort of one thing that I wanted to say at the end, if that's okay. So we went back to there's the issue of voluntary decision making, and I've already talked about the possible inappropriate influence, but we didn't see that really. But still, we had people who were, who, like if you look at the quotes at the bottom, I feel like a pioneer, I'm the special representative of the group. I mean, they really, this is very important to the people that we talked with. But and then I returned to the ethical challenges. I think my comments are basically not going to be surprising here, but except for the one part. Okay, so, and we did find that people felt that they made the decision themselves for the most part, and they were happy with that. However, at the very end, I returned to this idea of Nir Eyal's about participants not seeing this as a bad deal, and we think they didn't see it as a bad deal, and we think decliners declined for appropriate reasons, with the exception of what I mentioned, that maybe more help needs to be given them. But we also spend a lot of time talking about trying to translate a concept of altruism into the Thai setting, which we felt it really oversimplifies our findings. And more, we hit on the term reciprocity as a more valid framework for how people think about this, that they're giving back, they're paying forward, and here's some quotes that document that. It's like, to pay back to the study, it's done for the future. If people don't volunteer, there'll be no progress. And a number of people were happy being guinea pigs. I mean, they volunteered that. But, and I'm going to leave you with this last comment, which came from a community workshop in Thailand we convened at the end of April. We asked them to look at some of the excerpts of our transcripts that were anonymized and asked them what concerns they might have. And they raised one really important thing, and that kind of blew me away. And they said, don't let people join simply for altruistic motivations, because they felt that this was a sign, if there wasn't going to be a benefit to the participant, that this was a sign of the terrible impact of stigma and in the Thai culture of making people who are HIV infected feel compelled to participate, because to make up for, atone for the bad behavior that led them to acquire HIV. And the community workshop members were just adamant about this. And I'm leaving you with this because I'm not quite sure what to do about it myself, except to say this is concerning, that if people are really, people mention merit making as part of the Buddhist culture, and a number of our interviewees said that they wanted to make merit. But whoa, this is this is something that's concerning. So I wonder if you have any comments or thoughts, and then I'm done.
Well, thank you. That was great. I'll just say that on the last point, actually, wrote a paper which I'll send looking at motivations to participate in HIV vaccine trial research, and the notion of atoning, so to speak, for past behavior came up there as well. Whereas I think it's not just in Buddhist like culture that people go, I've done a lot of kind of bad things. I see this as a way to kind of do good in some way to sort of make up for the past, even if it's not the explicitly religious framework. I think that occurs here as well.
Yeah.
Ron Baird asked a question at the end of Serena's session. I'm just wondering, I know it's a little different, but just give some time to put out there about, just to change the topic a little bit, but I might have thoughts about this, about, just switch topics.
It's okay, yeah.
But how much effort should be given to, quote, cure research versus, adherence research, or other implementation? Any thoughts on that, or does that come up in interviews at all, or just any reflections on your own part on that?
It's an almost unanswerable question. I think if research is done, it's really important to try and understand, is there a good hypothesis generally? And I think the Bangkok group has been, I think, exemplary in finding conclusions, backing off from, pushing this as it didn't work. So, but whether, and of course, should CRISPR trials be done? Should gene therapy trials be done? Should the latest, hottest new scientific breakthrough? Should, phase 1, very expensive cancer trials be done? But I don't know. Do we have a limited budget for work on HIV? And is it more important to get people into treatment? And, there's all kinds of cost effectiveness studies that would show that Ron's perfectly right to raise this. And of course we should get people on treatment early. But I don't know. I don't know. What do you think? What does the group in the room think?
I think it doesn't move. I actually thought that at the very beginning, you said one of the functions of social science is not only to do very careful descriptive work, but to be able to reach a normative position as well. And so the question about whether this direction of research, given pressing needs in terms of the number of people who are in treatment, whose lives could be saved now were there more resources, whether, in a way, it's part of a bigger question, the whole investment in genomic research, the whole investment in precision research. Yes, it's important scientifically, but is this where we should be devoting our relatively limited resources?
So I have a response to that, and that is, in my study, we cannot address whether these trials should be done, and we cannot, because that wasn't our focus. Our focus was to try and understand whether people were joining these trials with eyes wide open, and our focus was on the individual level. The focus on the societal level is a different. Those are different people who need to make those decisions. That's true. But I think the community level is something that you can't look only at individuals. You have to look at the forces at the community level, both the institutions, the cohorts from which these people are recruited, et cetera. That those are also really big forces. But I'm glad you raised this, because in the end, even though I went through those different challenges and what Mir Ayal says we should do, at the same time, our data do not. They raise normative principle-based issues, but we cannot solve them. The ones you're addressing are just solved at a policy level. Or an IRB says, okay, this is way, way, way too risky. But that's not what the IRBs are saying. Somebody's launching it already. I don't know. I wish Serena was still there. She's doing that research.
Just in some ways, I wonder if you just might want to summarize what you would say to Near. So this is Near is a philosopher, I think now at Rutgers, actually. Oh, yeah. But,
okay.
But who said, this is too risky, we shouldn't do this research.
Yeah. He said it was a bad deal. He said if people join, they're making irrational choices.
They're making irrational choices. So
Yeah.
He said the research, how would you answer him?
I think he's wrong. I think people within their own value system are making really rational choices. When Jinta approached me in 2014 and said she was really worried about these new trials, and I said, well, I'm your partner then. But she was worried people would not feel they could decline at all. She was worried that people would feel pressured to join and that they wouldn't understand what they were joining. And when I listened to Serena's talk and I heard it's so complicated, I've heard talks about cure research for years now, and every time I hear them, I learn something because they are really complicated. So how can we expect people to really be able to assess the potential for risk and benefit? And so Jintanat wanted data that would help her figure out, was it being done ethically? That's what my study, I think, can help. And I think Near and I have agreed to disagree on this. But I think he's wrong, but I think he raises really important questions.
Well, I agree with you in your responses. And that was terrific work. Thank you. Yeah, what you're doing as a nation, I think, and really insightful and helpful and really a model and appreciate that.
Oh, thank you so much. Thank you for letting me come, even though I couldn't be there in person, because it's been such a pleasure to talk with you about this. And I just hope I can see you sometime in person.
I do have a few more questions.
Oh, okay.
Well, I was just going to thanks, Gail. Thanks for doing this. And what we can do is give us some years, fantastic.
Okay.
Further response to Ron's question, I mean, there's a little bit of an assumption that there is a little bit of research, but that might need to be or I mean, there's an assumption that well, if we didn't spend money on, let's just say, cure research, and there'd be more money than science research. And that's not necessarily true.
Right.
So it's a little bit like I think that fight for all. I mean, even thinking back and activists in the early days of the epidemic, we had to put resources to caring for people who were dying. And, was there enough and adequate resources for treating OIs and caring for people versus activists pushing for research to find treatments for this disease? And this is, to me, the evolution of still finding those diseases. So I think it's a valid question. And I'm someone who said there's not enough money to implementation science.
Right.
But I know that it's less seen in peer research that there would be more money for that. So it's depends how you frame the issue.
I think two things, but there's also a touch of course prevention research versus treatment, though that begins to blur a little bit.
Yeah.
And a lot of this is, the technology's going ahead in other areas. Some of the stuff, in terms of antibodies and the, CAR T stuff is in cancer sort of rolling out. And last, I think the fact that some of the trials, what's happening is they didn't work. And so, okay, we tried that, it didn't work. The remission didn't really last, so let's do that less. And so I think it's not like, okay, we're going ahead $1 zillion on this no matter what we found. I think it's so as in science, you put some money in, it doesn't work, try something else or tell it that is.
I think another argument is that that shows that it's not sustainable, that's a solution.
Right now. Floor is open.
I don't want to be misunderstood. No, I think the issue is that it's always good to be the guy Dickens who says, I want more, I want some more. And it's important to do that. On the other hand, to think that there are matters of priority setting, and that priority setting involves resources. And how we decide where we're, and this doesn't have to do with this particular notion, but the idea that precision medicine is going to solve our problems when we know that people at different levels of socioeconomic distribution die and live shorter or whatever.
Right.
I understand the excitement, but it seems to me we always have to keep in mind that we've made a decision in terms of relative expenditures. It's like Taylor's comment, why are we going to move? And there are protests out in the street of like, let's take care of, let's feed the planet before we
It's very suggested also whatever studies are done here on your research that primary outcomes would be the only but we got tank. What else? There you go. And we don't put all our eggs on just that one.
I want to come back though to sort of Gail. I think Gail's work is wonderful in terms of empirical methods, why people participate in research, why they decline. I think there's a huge need for that. I think in research that many people do. So just to put that out there, I don't know if other thoughts on that is either questions or Gail, your sense of other. It sounded like you skipped some of the slides there to rush to the end. I don't know if you did or.
I did, but it was returning to the ethical conundrums where we had these. So what I showed was that the risks were well managed, was that the benefits were thought by the participants to be very reasonable. In fact, the risk-benefit ratio was, for their point of view, positive, that informed consent, that people did feel, there was nobody who felt that they were talked into this, and that a lot of people felt they could decline. In the nuance of why I gave you the quotes and showed the trend over time for decision satisfaction, I think is really important, because if people were had unreasonable expectations. When Cure Research first started, there were a lot of articles written that said, people are going to hope for a cure. This is going to be therapeutic misconception in the extreme. And we didn't see that. Instead, what we saw was, I understood what I got into. Sure, I was disappointed, but the satisfaction with the decision basically didn't change. And that, I think, is really important data. So if you were collecting data, over time, I think, and you were only faced with retrospective interviews where people said, yeah, it was fine, I'm glad I decided, you could be subject to criticism like, okay, people are just saying that after the fact. But what we saw was over time that, that decision conflict didn't change much. And I think that's quite important. So then I left you with the societal value and the idea of altruism, which I think in the Thai context became quite nuanced, but certainly it is in many contexts. So maybe I'm really deeply into the Thai data. So so that was all I showed you basically are, the results. Okay?
Yes, that was great. Any final questions? I'm afraid if we clap it, they be overwhelming.
Okay, thank you so much. And Robert, everybody at the center, thank you for inviting me and letting me do this long distance. And yeah, so take care, everybody.